The second part of the objective assessment is the range of motion. The range of motion at a joint can be determined through either active physiological, passive physiological, or accessory joint range of motion. First of all, let us look at the active physiological. This assesses movement in the cardinal planes. During assessment, it is useful to quantify what you find, and this can be done through goniometry, using the protractors, or electrogoniometry, visual estimation, video or digital analysis. The choice of whether you use goniometry, visual estimation, or more video analysis will depend on time, availability of equipment, and also your experience as a clinician. It is important when looking at active range of movement to consider the quality of the movement. Is it smooth? Is there resistance? Does the joint deviate from the cardinal plane? Is there muscle spasm stopping it? And is there any contribution from other areas through a cheating or substitution manoeuvre? It is important to identify what limits the range of movement in the active range and compare this to the normal or opposite side. It may be necessary to ask the patient, do they feel pain or do they feel stiffness during the range? Relate to the client's symptoms and use as markers for reassessment in the future. Markers are an active range of movement that is performed each time the patient comes to visit for a treatment session and can be used to note progress of symptoms. It is then important to tabulate your findings. And on the right here you will see the tabulation of an active range of movement, for example, part of the active range of movements of the hip. And here we see that each active range of movement is noted down. So flexion for the left side and the right side, extension for the left side and the right side, and abduction and adduction. We note the normal side and then we consider the abnormal or limited side, and note down at what range of motion there's limitation and also what limits the active range of movement. Next, it is important to move on to the passive range of motion. The difference between active and passive range of motion will help us to differentiate between the symptoms from contraction of muscles and non-contractile components, such as ligaments. It allows the exploration by the therapist for the end feel of the joint. And there are 4 basic types of normal end feel: ligamentous or capsular tension, muscular tension, soft tissue apposition or approximation, and bony apposition or approximation. It's through the feeling of joints in the passive range that you will get to know how to determine and distinguish between each of these end feels. Sometimes you may feel a pathological end feel, and this is where it may occur when the expected outcome is not identified. It may feel empty, springy, or have a mechanical block. There are several variations to be considered to the testing of active and passive range of motion, and these may be used when you are searching for symptoms. For example, if pain doesn't come on readily after an active or passive range of movement, you may have to introduce certain other movements in order to bring on the symptoms. For example, application of overpressure may be used. This may be used when an end of range symptoms need to be explored further. You may also employ a repeated movement, so asking the patient to repeat the active range of movement several times and see if symptoms increase, decrease, or their quality or range of movement changes. You may also ask the patient to sustain a movement in a particular posture, and this will indicate a more postural type of dysfunction. The speed of movement is also important, as symptoms may come on at one speed but not another. And finally, combining movements is a good way to bring on symptoms. And this can be done when in the cardinal plane the symptoms haven't been reproduced. But if you bring on in a movement in a more functional plane, this may be the symptoms may be revealed.